Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. That is on a very important topic, that is biologics and beyond. What's next in the therapeutic pipeline for arthritis on the occasion of World Arthritis Day? And as we know that this topic is a very important, so we need someone who is expert. So without any further delay, I would like to invite Dr. Ved Chaturvedi sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, DM, and he's a senior consultant at the Sir Ganga Ram Hospital and Vice President of Asia Pacific Rheumatology League, APLAR. So, without any further delay, I would like to invite Sir and hand over this webinar to Sir. Sir, the stage is yours. You can proceed from here. Sir, over to you.
Good afternoon, ladies and gentlemen. I hope these slides are visible. Uh, these slides has to be increased in size or they will remain like this. These
On the right bottom of the screen, you will have option to full screen, sir. You just full screen your screen.
Just a minute. Let me put it full. Yeah. So my brief is to talk about biologics and beyond. Now, I had served in army. That's why this rank is put there as a lieutenant general. So I was in army hospital. A very interesting story I must tell you that we used to have. Look, these diseases were all they were always there. Whether it's a cancer or it is an autoimmune disease, they were always there. Only thing we didn't know how to recognize them. So a lot of people ask, okay, nowadays arthritis has become more. I say no, it's not that. Arthritis was always there. Cancer was also there. Heart attack was also there. Probably we start recognizing them more. So first is recognition. So when I did my rheumatology DM, that is from SGPGI, I got admission in 1989, one of the few first batches of DM program in the country. So I said, yeah, I have never seen, because I was a physician. I was more busy with the pleural effusion, heart attack, this stroke. But these type of cases like SLE, systemic sclerosis, rheumatoid arthritis, I don't know whether I always thought I have not seen such type of cases. So first is the recognition. Then came the drugs. So normal drugs initially was painkiller. So you have a pain, use painkiller. You have inflammation, use anti-inflammatory. They are called as the inflammatory drugs, or they are called as anti-inflammatory drug. Like earlier was aspirin, then came indomethacin, and so many drugs which came, diclofenac sodium. Then came a magic drug, steroid. That was also anti-inflammatory. So they why it is moving? Just a minute. Let it remain like this. No, no, just go the first slide. Just open the first slide. Yeah. So the drug was no was the two drugs were very popular. The one drug was painkiller or anti-inflammatory. Another was the steroid. So these both drugs had their own problem. Otherwise, they are good drugs. They reduces pain. After all, even the new drugs, what are they doing? They are reducing the pain and swelling. So they were also reducing pain and swelling. But first thing, they could not stop the structural progression. So that is number one. That joints kept damaging itself with the inflammation. So swelling is less, but the damage is going on. So then they did further research and came the drugs like methotrexate, sulfasalazine, oral drugs. Biggest problem with these drugs are that they are good drugs, but only 40-50% people they respond, and about 30 to 40% they don't respond. So then came the drugs like biologics. Now, why they are called biologics? Because probably they are produced with a different technique, and they are very complex molecules. They are not like ordinary molecules which can be made in ordinary factory. They are complex molecules. They are live. They have they are live molecules, and batch to batch purity is important. So my topic is to talk about biologics. So my topic is not to talk about the medicines for the arthritis. My topic is to talk the new drugs in arthritis, which are called biologics, and what is happening in the future, biologics and beyond, for the what next in the therapeutic pipeline for arthritis. Next, please. Next. Yeah. What is the idea? Why we want to discuss it? We want to, because I want this crowd to understand about the current biologics, what they should understand, and the newer drugs, which is called as target synthetic DMARDs in arthritis management. So one class of drugs are called biologics, another class of drug called target synthetic DMARDs, like JAK inhibitors, and review key emerging therapies in the pipeline, what is going in the future, and discuss mechanism of action, evidence, and safety consideration, and translate pipeline knowledge into clinical decision making. Next. So, as I was telling you, unmet needs in inflammatory arthritis. Tell me, if suppose an ideal drug is discovered, then you don't need any drug. So, suppose I have, say, this is ideal drug for, say, diabetes. It cures all forms of diabetes. Then you don't need any drugs. Why so many drugs? Same as arthritis. It means there are few people who respond to drug A, another will B, another will C. Somebody will respond from the beginning, and then it fails. Something happens and they don't respond. There are few patients who from the beginning they don't respond. So that is called as primary and secondary responses. Primary response means initial response, and secondary non-response, as I said, failure, you can say. So primary failure, from the beginning they are not working. Secondary failure or non-response means, so we have some drugs which has primary failure or secondary failure. Another issue is the heterogeneity of the disease mechanism across patient. Means, what is heterogeneity? You always feel, look, if I'll give anti-TNF drug, they will respond because TNF is so important for the arthritis. But it doesn't work. It means the mechanism of action in this another patient is different. So there is a heterogeneity. Safety concerns and long-term adverse events. Yes, it's different for different patient. Safety, some it suits, some patient doesn't suit. Some patient get tuberculosis, some patient doesn't get tuberculosis. Need for disease modification and prevention strategies. So if you can't treat a drug, a disease, you can at least modify. Somebody has a huge joint swelling, but you can always modify it to become less joint swelling, and which we all which may not be remission, but a low disease activity. So modification and prevention strategy. And can we prevent it? Suppose I have a rheumatoid arthritis, and my son, he also start getting little aches and pains, and I know it looks like same only which I had a disease. So probably, is there any drug to prevent it? Next. So what are the current scene as on today? I can tell you, youngsters should know that there are about 5 countries which are making aircraft. After all, there are 200 countries. Why they are not making aircraft? Only England makes it, America makes it, Chinese makes it, France makes it. So one must be, I must be missing. So there are 4 or 5 countries which are making the aircraft which you fly. You can imagine what a monopoly. Why other people can't make it? Same thing is biologics. Believe me, hardly 5 or 6 countries, 7 countries may be making biologics. It means it is a complex structure. It is something like you are making an aircraft. Aircraft is also a complex structure. To make a car is easy, but even to make an engine of the car is also difficult. Not many countries are making car engine. They are making car, but not car engine. Even India can't make the aircraft engine. Whatever we say that we are making this aircraft, that we don't make it. It is the engine comes from outside. So you can imagine, even if the engine comes, it is difficult to make even body. So that is how the research is. Same as biologics. When biologics came, they came with a promise that no, methotrexate does not work in all the patients, sulfasalazine does not work in all the patients, and here is a drug which is a magic bullet. It works in most of the patient, and it is effective so much. It's not small. They are very effective. They are magic drugs. They are magic bullets. And the first biologics in rheumatic condition came is infliximab. Now this, it was an attract trial published in rheumatoid arthritis, and the author was Ravindra Mani, Mark Feldman. There were two people. What they did, they started using infliximab, and this infliximab was already this was a drug classified under TNF inhibitors. It inhibits a cytokine which is tumor necrosis factor. Now, this is the cytokine. People research that it is high in many conditions, including septic shock. So, uh, even in a country like America, a lot of people die of septic shock. If a sepsis develops, you even if you're admitted in ICU and everything, but you die. 90%, 80% mortality. So they found that TNF is very high. So they made a drug called anti-TNF for this septic shock. They were very happy that they had made a drug, and the drug company was sharing plow, and they thought they will become very rich by making this drug. But in the lab, it works, but in the current patient, it didn't work. So they were surprised it doesn't work. So they were keeping, so this drug was discarded. But since they had made so many molecules and so many vials, they were keeping with them till the Ravindra Mani and Mark Feldman. Ravindra Mani approached them that TNF is high in rheumatoid arthritis also, and they thought maybe we'll use less dose than the septic shock, and then rest is the history. When they used for rheumatoid arthritis, it worked, and it worked so great that even they were surprised it is working so nicely, because there was no other drug which was working like this. And the infliximab paper came in the Lancet, that was called Attract trial, and they realized they have found a fantastic molecule which they called as TNF inhibitors or TNFI. And infliximab was given IV, and it was given every 2 monthly, and initially with the initial loading dose was given, and then given every 2 monthly, and it was IV drug, so you require a hospital admission. In the Attract trial, they have written that patients who were given infliximab, a fair percent of patients developed tuberculosis. So the tuberculosis and infections were the major side effect. So that time I was in army hospital, and I was the earliest user of this country. So we also use it, and we what we realized, we I read a track trial, and I realized most of the tuberculosis is occurring early. And what is happening early was loading dose. So I said remove the loading dose. So I removed the loading dose, and there were hardly any tuberculosis. So my hypothesis was no loading dose, you will have no tuberculosis. So our whole country started using it. So that is why people know me as a father of biologics in this country, because I was the first to use these biologics, and good for about 5 years I was the only person using in this country, and we use it not in one or two patients, we use in thousands. It was very costly medicine, but army could afford it. So we started using infliximab, both for rheumatoid arthritis and later for the ankylosing spondylitis. And then people realize, why IV? There should be some drug it can be given by his patient himself. So that came the subcutaneous drug like etanercept and adalimumab. Little differences are there, but for this crowd, just simply to remember, they are called as TNF inhibitors because they inhibit a cytokine TNF, which is high in rheumatoid arthritis, and they have very good efficacy. But yes, side effects issues are there. Then not only people realize that TNF is the only cytokine, they studied other cytokines like interleukin 6. They said even if we interleukin 6 is also high, so let's block IL-6. So they blocked with tocilizumab. This drug is available in the country, and sarilumab is not available. So in India, they started using this, and they found it is very effective drug. And then came the IL-17 inhibitors. Then came some other cytokines, especially for for encouraging spondylitis, other biologics by blocking interleukin 17. So there are different pathways we are dissected, not only TNF inhibitors, not only tumor necrosis factor, there's IL-6, there are IL-17, and you can target B cell, you can target the other pathways like JAK-STAT pathway inside the cell. So then came the drug like IL-17 inhibitors like SECU and ICSI, and bemkizumab, which which blocks both the A and F receptors, and B target B cell therapy, which is very well known, rituximab, which was already a drug used in oncology against the B cell tumors, and the T cell stimulation signal blockade is abatacept, and of course now the JAK inhibitors everybody knows that JAK inhibitors are oral drugs. They are as effective as biologics, and their names are tofacitinib, baricitinib, and upadacitinib. All these drugs, except the bemkizumab and sarilumab, everything is available in our country. Next, and we should be feel proud that most of these drugs are now made in India also. So why? What is beyond biologics? Now, these are beyond why it matters, because we want more precise, and we want more precise. Either you target the multiple pathways, like you are targeting TNF, but you target with the T cell, B cell therapy both. So multiple targets. If you use multiple targets, it may work better. Or may you target not only the cytokine, you target the cells. It's cellular therapy for durable control, or not only IV and subcutaneous, because people hate injections, frankly speaking. Even if somebody says, if I need injection every 7 days, I'll be little maybe depressed. So oral drugs, I think, is still in our psyche. We always feel oral drugs are better. So oral drug like selective kinase inhibitors with improved safety. Next. So the next generation cytokine inhibitors, like you have IL-17, we have secukinumab. We are using it for the secukinumab is a drug used for psoriasis and psoriatic arthritis and spondyloarthropathy. They were blocking only 17, but it has a two receptors, 17A and F. So they are dual receptors like ICSI and other drugs. So they started using those drugs, and IL-23 variants and immune cell directed biologics like the the PD-1 depleters. Can we just hold on? Just hold on. Uh, ma'am, I'm in the meeting. I'll just give you a call after 15 minutes. So PD-1 depleters and see the pathogenic T cell targets, cellular therapies like very popular, which we all know, CAR T cell and CAR T Rex, and now the CAA, so CAR T cell. So that is a, and bispecific antibodies and oral biologics like molecules and biomarker driven precision medicine. Next. Now, this drug, it's a IL-17 blocker. But what is the difference between bimsicumab and the secukinumab? Secukinumab blocks only IL-17A, while this blocks both 17 and 17A and F, so dual blocker. So maybe it is more effective. And there's a clinical evidence that if you use both dual blockers, shows superior skin and joint response in psoriatic arthritis, because psoriatic arthritis, the target is IL-17. So initial first drug came as secukinumab. Now the newer targets are you target both the receptors, bimekizumab. So bimekizumab is used. Efficacy reported in axial SPA, as I said, psoriasis and axial SPA, and 3-year data demonstrates sustained control of inflammation. So these are the EULAR 2025 updates came. Next. So basically, indication for this drug, which may come in this country also, is psoriatic arthritis, axial SPA, and ankylosing spondylitis. And injection schedule and monitoring is basically these are the subcutaneous drugs, and adverse event, all IL-17 blocker, whether secukinumab or this, the adverse events are mucocutaneous candidiasis and nasopharyngitis. So we always monitor for other infections, but most common is candida and nasopharyngitis. Next. Then another biologics, which is this is called as rosanilimab. So this is a PD-1 and T cell depleter. It has a novel mechanism to target the PD-1 receptor plus pathogenic T cells in rheumatoid synovium. The phase 2 trial is already available. This called Renoir, shows promising ACR response in refractory rheumatoid arthritis, may offer durable response by depleting autoreactive clones. So what is happening? Probably we are working, yes, this drug is effective for 40-50% patient. So some patients are not responding, so they use another drug. And this drug, which is rosnilimab, is effective because it depletes PD-1 and pathogenic T cells in rheumatoid arthritis synovitis. It works in refractory rheumatoid arthritis. Next. So clinical safety, it is basically maybe best used in selective refractory or biomarker positive patient. Potential for disease modification if pathogenic clones are reduced. Theoretical infection risk is definitely there, so you must monitor closely. Next. Abatacept was a drug. It's not a new drug. It was available in the country. Then it went probably because of poor marketing. It's a fantastic drug, basically. And this it was a Lancet trial. Abatacept reduced a progression to clinical RA in high risk individual. Now, who is a high risk individual? Suppose my father is rheumatoid arthritis, and I am also having aches and pain, and I have rheumatoid factor positivity, and I feel that I am also developing rheumatoid arthritis. So I have a risk of developing the rheumatoid arthritis. So the abatacept was a very good drug for prevention and early intervention. 6-month course reduce MRI inflammation and symptoms. Effects persisted in follow-up, raises possibility of disease interception strategy. So abatacept is a fantastic drug. Next. Now you have so many JAK inhibitors. We already know about tofacitinib. We know the upadacitinib. We know baricitinib. Now another JAK inhibitor is TYK2 inhibitors. Their TYK2 inhibitors are coming, and the drug which is coming is deucravacitinib. Very difficult to pronounce these names, and other names will come in pipeline. What they do, this TYK2 inhibition modulates IL-12 and 23 and type 1 interferon, and it's approved already in dermatology, in psoriasis and psoriatic arthritis. Oral options with distinct mechanism from JAK1 and JAK2. So it's oral drug. It's a different mechanism. It works with the TYK2 inhibitors. So that is how the deucravacitinib will is working. Let's hope it's not available in this country, but it is approved in the dermatology. JAK inhibitors, next generation selectivity. Now, more and more selective JAK inhibitors come now. Upadacitinib has been launched in this country by MSN, and maybe I think by in the next future by Radies. And it has a broad utility across rheumatoid arthritis, psoriatic arthritis, other inflammatory disease. It is something like, even if you don't know the diagnosis, you use the JAK inhibitors, it works. So that is very popular amongst, in spite of the side effects and black box warning that it should be used only by the rheumatologist. It is widely used and misused because it can be used for all the diseases. It can be used for rheumatoid, it can be used for psoriatic, it can be used for ankylosing spondylitis, can be used for AOSD. So regulatory updates, but the box warning at 10 years data says that yes, it has the same toxic effects as the biologics. So you must monitor for infection. You must mark another major side effect is venous thromboembolism, so more prone to heart attack. That's why the black box warning is there. So lot of rheumatologists and dermatologists say, I have not seen, I'm using for last 10 years. But people don't realize those patients will not come to you. They will go to cardiologists. They will come in the middle of the night when you're sleeping, and they will come with a heart attack. And also, you must warn the patient of the infections, and you must keep a track of those patients who are taking JAK inhibitors, whether they are not admitted in some emergency ward with a heart attack or thrombosis. I used to also think same like, no, probably it's bunkum. It is, I'm using for so many years. But then I saw first time a patient who was having the wrist pain, and I always thought it is a wrist pain. For some reason, I probably did the ultrasound because we have ultrasound machine in my office, and I realized that wrist joint is okay. There was a thrombus in the nearby vein, and which was going all around. So that the first time I saw that your tofacitinib can, yes, definitely leads to the, otherwise pains for us is always thought arthritis, but she didn't have any arthritis or synovitis or synovial effusion. She had a thrombosis of the whole vein. So next generation molecule will come with greater selectivity, and let's see how they work and how the side effects, whether it can be less. Next. Now, another set of new biologics are against the GM-CSF, IL-33, IL-36, and other cytokine. Basically, these IL-33 and 36, these are early stage targets with potential synovitis modulation. Basically, they are used in allergy, asthma, but now even in synovitis modulation, because the if you target 33 and 36, initial result shows that it is effective. And GM-CSF inhibitors like Marvilimumab shows promise in rheumatoid arthritis and may remain exploratory. Interpret early data is used cautiously. So let's come the more results. The only phase 1 or phase 2 trials are available. Let's see what happens. Maybe some animal models, maybe, but they are all initial signal that it does work. Next. Next, please. Next. So now bispecific and multi-specific antibody. Now you have next, please go back. Please go back. So now you have an antibody which against works in one antigen. But suppose you have a dual antibody. Bispecific antibody means it works against two molecules. So it is working against IL-17 also, it is working at TNF also. So you give a antibody which works against T cell also, against B cells also. So bispecific and multi-specific antibody are already available. Simultaneous blockade of two cytokines or two cell markers like TNF or IL-17 in development. Potential benefit is improved efficacy and reduce escape variants. Challenges are complexity, manufacturing issues, and of course the safety signals. Next. Now, biggest issue with the injection, as I said, everybody is scared of injection, so people want oral drugs. Now, injection, first thing, you need a needle, you need a syringe, you have to inject yourself. You require a fridge, a cold chain. You can't carry in the pocket. So tablet you don't require it, and tablets are easy to make. Is more so oral drugs which are as effective as biologics. They may not be biologics, but they are as effective as biologics. So then they came the like peptide therapeutics and small molecules. JAK inhibitors are called small molecules. Why they are called small molecules? Because biologics are large molecule. So in comparison to biologics, they are small molecules, easy to make. You make in a small pharma company, while for a biologics you require a bigger company, and they mimics the biological effects. Advantage is oral administration, cost is less, and adherence benefit is there. People will use more injection. People will always ask, okay doctor, when we'll finish this injection. Tablets they won't ask, they'll keep taking. Challenges are bioavailability and the durability of effect. The next probably the bioavailability of injection is more. Next, cellular therapy. Now whole world is talking about CAR T cell and CAR T regulatories and T. CAR T approaches target pathogenic B and T cells or autoantigen expressing cells, and CAR number two is CAR Tregs aim to restore regulation rather than deplete it. So they restore the regulation, where the early trials, that is the of the CAR CART, early trial shows promise in antibody mediated diseases. Autoimmune CAR T cell is expanding. I just heard 2 3 lectures recently about the CAR T cell. It's very promising. Next, you must have heard about CAR T cell and leukemia. Clinical trial design trends are also changing. How they are changing, adapting platform trials and biomarker enriched cohort, early prevention trials and treat to targets at a risk population, and use of synovial biopsy. I myself is in favor of synovial biopsy. I went to APLAR and presented intervention rheumatology. Probably I have always done things which was not which was earlier than the its time. Like when I did synovial biopsy as a rheumatologist, I did in 2004, and people were laughing at because I was doing synovial biopsy through a scope. Now even clinical trial say these they won't work. It doesn't work. Like your CRP is less, dash 28 is less. They want to see at the cellular level what is happening at the cellular biopsy. So you do a synovial biopsy and demonstrate that inflammation is less, and you can classify rheumatoid arthritis into a severe rheumatoid arthritis or mild rheumatoid arthritis. So let's see, that happens in oncology, that happens in nephrology. So synovial biopsy will come, and molecular endpoints as a surrogate markers. Next, biomarkers in precision medicine, synovial phenotyping. Actually, you will not believe, I call it synovial documentation. Like skin, you document this is psoriasis, this is dermatitis, this is that is how you classify these skin diseases. You say it is macule, it is papule. Same thing is the if you put a scope and see the synovium phenotyping, cellular and molecular level to guide therapy. Peripheral biomarkers, of course, they are as it is popular. You can do serology, gene signatures, proteomics, imaging biomarkers like ultrasound. We are doing. I was the first one to start ultrasound in this country to in 2003, and still using it. So they will also use to monitor early inflammation and response. Next. Next, safety is the most important. Look, patient asks 3 questions once as for a clinician. I'll write, okay, this is the drug. So first question he asks, doctor, is it safe? So safety remains the number one. Then he will ask, doctor, how long? So duration of the treatment. And third, he will ask, is the cost. So that is the how it goes. So it is very important, especially safety in terms of infection, in terms of venous thromboembolism, in terms of malignancy concern with JAK inhibitors. So whether they are class and the class specific side effects of for biologics, need for screening like tuberculosis, hepatitis, and vaccination optimization, like which vaccine can be given, and importance of registries and pharmacovigilance for new modalities. Very important. We are poor in this country about the registries and pharmacovigilance. We have just heard about the cough syrup after it is marketed, and we don't know which what. So it means there's a poor pharmacovigilance. Even first time when the death occurred, it should have been nipped in the bud. So pharmacovigilance is very, very important, both by doctors and both by those those who are actually legal responsible. That is the drug authority or drug inspectors, so called. Next, safety of novel modalities, like suppose you use bispecific antibodies. So probably it will be a combined immunosuppression. So you share more vigilance. The PD-1 depleters, theoretical risk of immune dysfunction. So monitor opportunity infection and CAR T cell cytokine release syndrome, less in autoimmune construct, but more in the when it is constructed for the leukemias and long-term immune effect. So safety of whether it's a PD-1 inhibitors, CAR T cell, or bispecific antibodies has to be kept in mind. Next, when to new things will come and new guidelines will come when to switch class versus within class switching. Means suppose I'm using one drug and if it is not working, should I use from the same class or I switch the class? So it's called class switching. Consider mechanism of failure, whether primary non-response versus secondary loss of efficacy, which I discussed earlier, and role of combination therapy in selected refractory cases with caution. So refractory means use T cell inhibitor, you are saying B cell inhibitor also. So that those therapies will be tried in refractory. Let's see what happens. Though it sounds exciting, next, but it can have a lot of side effects also. Maybe you are targeting T cell also, B cell also. So there are a few case studies. Today only I had a patient exactly like this, that nothing is working. Whether the diagnosis rheumatoid arthritis, the methotrexate does not work, leflunomide does not work, the anti-TNF does not work, the JAK inhibitors don't work, then what to do? So consideration maybe the triple the trial enrollment with the B cell therapy or CAR T cell therapy, or the and the rosnilimab and workup should be done. All these patients should be subjected to sinus biopsy, and we must monitor for the infection screen, because if you're using all these drugs and share decision making between patient and all, and they should be treated aggressively because they will lose the joints otherwise. Next. And another second case is you a patient of ankylosing spondylitis and persistent axial symptom despite you have used the anti-TNF, now you use the secukinumab IL-17, then another IL-17 like bimekizumab, which blocks both A and F agent, they may work. So consider trial for novel pathways, access comorbidities also, especially IBD and infection, and imaging to guide choice. Next. How to discuss pipeline with patients? So we must discuss a shared decision making, that look, these are the drugs which are available, these are drugs in pipeline, these are pros and cons. So you must discuss with the patient, explain trial participation, follow up, randomization. So all things we should discuss with the patient, because today patients are reading much more than the doctor. So you must discuss openly. It can, if they want to use it, otherwise, so don't keep with you. So basically, very, very important to discuss with the patient. Next. So I think the last one or two slides, um, these are research gap. There are many drugs, but to head trials are very few. So head-to-head comparison and long-term registries are required. Better predictive biomarkers and synovial guided therapy selection, they are all waiting, and prevention and early intervention trial to change disease course. All this thing looks very nice theoretically, but this is required. Some countries are doing, some countries are not doing. So some centers are doing is let's fill up this research gap and future directions. Next. So last slide, probably the last, yes, last slide. So what are the five bold predictions? What will happen? It's like I predict what is going to happen in future, like an astrologer. What is going to happen is the GMCSF against GMCSF, biologics agents find a nick in the niche in the pain dominant inflammatory. So basically, this drug will come with the pain dominant inflammatory phenotypes is there. So a lot of patient who has more pain, they will be used with GMCF CSF inhibitors. And TIC2 class secures a label role in psoriatic arthritis. So this is another class of drug which is going to come. And for osteoarthritis, disease modification will be available, and synovial pathotype guided therapy enters guidelines. Maybe it will come like like I do a biopsy and I find lot of collection of lymphocytes. The drug for those patients will be different. So just like in nephrology, in lupus you have a call as class 3, class 4, then they are treatable, but class 5 is a hopeless. So that will synovial pathotype, that, and according to that drug will be used. And one antigen specific toleration or treg program shows durable remission signal. So that is how. Next. Next. Yeah, so summary, takeaway: biological landscape expanding with new targets and formats, very fast changing. Adopt cautious optimism, prioritize safety and evidence. So most important is safety, and most important is evidence whether it works or it doesn't work. And it is expanding very fast every day. It is changing, so you should be up to date. Implement biomarker driven choices where available, and enroll suitable patients in trials. Thank you. I think I have finished. Next, let me see whether if anything is available. And next, I think the slide. Next slide. Yeah, so these are the selected references that is going to change, like key trials of all these drugs which I discussed, whether bimekizumab or abatacept or rosnilimab, and of course the results in 2025 as they already coming. There is a CAR T cell and CAR T reg reviews, and of course TIC2 and JAK safety reviews. Even for me, who grew with the biologics, I find it is very difficult to cope up that what to use and what not to use. And I think there will be a lot of discussion with your colleagues. So you must have a autoimmune board, autoimmune disease board, like a tumor board. Like tumor board is very popular in oncology. So you sit down 3 4 people and decide. It's a combined decision of more specialists, one or two, three, four specialists. You have a pathologist, you have a immunologist, you have a clinical man, and patient relative. So that is going to happen, so that we know that yes, we have all discussed, and in the interest of patient, we are using the best drug. Thank you so much. Thanks.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. And I really hope this session knowledge is going to help all the participants who have joined this webinar, sir. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
No, actually, I had to leave because we started a little late. I
Yes, sir.
can
No
take
issue,
one
sir.
or two. We can took
Okay, sir.
one
We will
or
take
two.
only one question, sir.
Yeah, yeah, yeah.
One question related to, sir, what are the emerging targets and novel pathways currently under the investigation beyond TNF and IL inhibitors?
Yeah, I already discussed the newer targets will be, like I said, the PD1 inhibitors. The targets will be the the cellular target like CAR T cell. The other targets will be complement. So all newer molecules will be targeted, and as the research will go more and more, and like you have a JAK inhibitors, they are targeting the JAK-STAT pathway. Then you can target the other pathways in the signal transduction. So that is how which is going to happen. So they are dissecting more and more of the targets, and they are making newer drugs for that. Thank you.
Thank you so much, sir, for answering this question, sir. And I would like to thanks for taking out your important time and sharing your knowledge, sir. I hope it will be very much impactful, and you have done justice to this topic, sir. As we are running out of time, sir, we would like to connect in future also with different topic. Till then, take care of yourself. It was great honor to host you, sir. Thank
Thanks.
you,
Jai
sir.
Hind.
Jai Hind, sir.